Hypoplastic left heart syndrome is one of the cyanotic congenital heart diseases with increased pulmonary blood flow. Its name is quite intuitive. Hypoplastic left heart means that the left side of the heart, including the left ventricle, the ascending aorta, and the mitral valve, will be underdeveloped, usually to such a severe degree virtually no blood goes through the left heart. Which means that the only way for blood to leave the heart overall will be through the pulmonary trunk. And then, from the pulmonary trunk, some portion of that blood is going to go through the ductus arteriosus, if it remains patent, to the aorta. And so, all the blood going to the systemic circulation is going to first have to enter and traverse a small portion of the pulmonary circulation. There is essentially no way to reach the aorta without first going through the pulmonary trunk to then pass through the ductus arteriosus. The ascending aorta, the mitral valve, and the left ventricle are functionally non-existent. So, also, if all the blood has to go through the pulmonary trunk, then, by extension, all the blood, both for the pulmonary circulation and the systemic circulation, has to be pumped by the right ventricle into the pulmonary trunk. That's why hypoplastic left heart syndrome is considered one of the univentricular heart malformations, because while there is a left ventricle, it's so underdeveloped, hypoplastic, that functionally it's as if it didn't exist. So, to all effects, it's as if the heart had a single ventricle, an univentricular heart. So what happens to the blood coming from the lung, the oxygenated arterial blood coming into the left atrium? Well, since it cannot go into the left ventricle, either because it's too small or because the mitral valve is completely atretic or stenotic, or simply because the volume of blood that could go into the ventricle is insignificant, what's actually going to happen to the majority of the blood that reaches the left atrium is that it's going to go to the only other chamber that the left atrium borders, the right atrium. There is a communication between them during embryological life, the foramen ovale, and since the blood in the left atrium can't flow to the left ventricle, the pressure will eventually force it to flow to the right atrium through the foramen ovale. There, it will mix with the deoxygenated blood coming from the vena cava, and this mixed saturation blood will then be pumped from the right atrium into the right ventricle. The right ventricle shall pump it into the pulmonary trunk, and then some portion of it will go through the pulmonary arteries to the lungs, and another portion of this mixed oxygenation blood is going to go through the patent ductus arteriosus to the aorta, and from there to the rest of the systemic circulation. Therefore, since we have arterial and venous blood sharing the same chambers in the right atrium and the right ventricle, and also a single vessel in the pulmonary trunk, we are going to mix oxygenated and deoxygenated blood, and thus the blood pumped into the aorta and the systemic circulation will be of mixed saturation, lower than normal, and will not be able to fully support the oxygen demand of the tissues. So, there we have it, why it's a cyanotic heart disease. We have mixing of blood between the oxygenated and the deoxygenated, and therefore not enough oxygen is reaching the tissues, giving the neonate skin a bluish coloration. Analogously, since all the blood has to go through the pulmonary trunk to then reach the aorta, we can deduce that the pulmonary trunk will have to handle both its normal flow and the aortic flow, so twice what would be normal. And that's why it's considered a cyanotic congenital heart disease with increased pulmonary blood flow in its classification. And finally, since the left ventricle is non-functional, the blood has to bypass the left ventricle in order to reach the systemic circulation. And so, we need at least one entry point for the oxygenated blood into the right heart and one exit point from the pulmonary circulation to the systemic circulation. Otherwise, we couldn't take the blood that's coming from the lungs to the heart and send it back to the systemic circulation. So, as you probably can deduce, the patent foramen ovale and the patent ductus arteriosus really must remain patent in order to preserve life, and it is in our interest to make them remain so. Personally, I like to think of hypoplastic left heart syndrome as the anti-pulmonary atresia. No, of course, it's not exactly the inverse. After all, we are not talking about just aortic atresia. We are talking about left ventricular hypoplasia. We also have aortic hypoplasia and mitral hypoplasia. However, that's not the single defect. It's greater than that. What I do mean is that in pulmonary atresia, blood can't leave the right ventricle, and so blood arriving in the right atrium has no other choice but to get into the left heart, first through the left atrium, then go through the left ventricle and be pumped into the aorta, and all the blood that's going to reach the pulmonary trunk is also going to the aorta and then coming through the patent ductus arteriosus. And in hypoplastic left heart syndrome, we have the opposite. The blood that arrives in the left atrium can't go into the left ventricle and also can't leave through the aorta, and so it has no choice but to go into the right side of the heart, first through the right atrium, then be pumped into the right ventricle, and then into the pulmonary trunk. And all the blood that's going to reach the aorta is coming from the pulmonary trunk through the patent ductus arteriosus. So, both in pulmonary atresia and in hypoplastic left heart syndrome, we have one of the great vessels receiving all of its blood from the other one through the patent ductus arteriosus. If you have been watching other videos of congenital heart disease from my channel, it definitely won't come as a surprise to you the fact the etiology for hypoplastic left heart syndrome is unknown and suspected multifactorial. This is actually quite common for heart malformations. Since in embryology lots of cavities form by being filled, like for example a balloon gets its final shape by being inflated by having air blown into it, also heart chambers get to their correct size by having blood blown into them. So, one of the most likely explanations for the pathogenesis of HLHS is primary aortic valve or mitral valve atresia. If we lose the mitral valve, for example, if it doesn't form, then blood has no way for getting into the left ventricle from the left atrium, and if blood doesn't fill the left ventricle is not going to grow. This also explains why the ascending aorta is also likely to be hypoplastic, because blood isn't being pushed into it, at least not the correct amount. Some amount of blood is going to get into the ascending aorta backwards in a retrograde fashion from the patent ductus arteriosus. It's actually necessary if you want to irrigate the coronaries. However, this will be a much lower flow than it would be expected in a normal heart. It's also possible it could derive from premature closure of the foramen ovale, since in fetal circulation that would prevent blood coming from the vena cava into the right atrium from flowing to the left atrium and then to the left ventricle. Also, it would fail to fill the cavities of the left heart and therefore lead to hypoplasia. And it's also possible that could be derived from a misalignment of the atrial septum. As is common with congenital heart disease, there are many possible causes that have been proposed, and there is undoubtedly some degree of heritability, although certainly not 100%. Hypoplastic left heart syndrome has an incidence of 2.6 per 10,000 live births and is more common in males than in females, with a rough 1.6 greater incidence in males. The disease was a substantial cause of neonatal death before the advent of the staged reconstruction, with an overall mortality rate without surgical treatment reaching close to 100% in the first 2 weeks of life. Survival without surgical intervention is virtually not possible. The first of the surgical approaches, the Norwood Procedure, is easily the most dangerous of them. Therefore, survival to the time of hospital discharge after a Norwood procedure is close to 75%. However, amongst those patients who have undergone a successful Norwood procedure, the survival to hospital discharge after having the second and third stages, the Glenn and the Fontan operations, is close to 90%. Since the absence of the left ventricle is quite conspicuous, the disease is usually diagnosed through Doppler echocardiography on obstetrical ultrasound. Should it not be diagnosed during gestation, it usually presents with cyanosis at birth and worsening symptoms of shock as the patent ductus arteriosus and the foraminal valley start to close, a sign the window for treatment is finishing. Thus, its differential diagnosis will usually be other cyanotic congenital heart defects. Once the neonate is born, it's important to collect arterial blood gas to verify and correct the presence of a metabolic acidosis. However, the diagnosis will most likely be made by the gold standard Doppler echocardiography, which I'll show with quite some ease the left ventricular and ascending aorta alterations. A karyotype is also indicated to search for chromosomal abnormalities, which are sometimes associated, as well as a Doppler ultrasound of the head and the abdomen to exclude associated malformations. If performed, an electrocardiography will also display findings characteristic of the absence of a left ventricle, such as right axis deviation and right atrial and right ventricular hypertrophy. Cardiac catheterization is no longer done, usually as a diagnostic tool, since the Doppler echocardiography is usually more than enough to close the diagnosis. However, it's still performed routinely before the second and third stage procedures, the Glenn and the Fontan procedures, particularly to calculate the pulmonary vascular resistance and ensure the patient's pulmonary vessels pressure is low enough to accommodate the next stages of the surgery. And speaking of then, the treatment of hypoplastic left heart syndrome is usually performed either through cardiac transplantation, should the standard procedure prove non-effective or unfeasible, or through the classic staged reconstruction, a series of 3 procedures, Norwood, Glenn, and Fontan, performed a few months apart. Before these procedures can be attempted, however, we need first to keep the child alive. So, we must ensure that the ductus arteriosus and the foraminal valley remain patent, allowing blood to circumvent the left ventricle. So, We'll administer prostaglandin E1 to keep the ductus arteriosus patent, and if the foramen ovale is not completely patent, restricting the flow from the left atrium to the right atrium, it may also be necessary to perform a percutaneous catheter, balloon or blade septostomy and atrioseptostomy, cutting off the membrane between both atria. And once we've taken care of these present concerns, we get to the extremely classic and extensively discussed staged reconstruction. The idea here, as often is in congenital heart disease, is to match the stronger chamber with the heavier load. In HLHS, we basically only have one ventricle, the right one. The left ventricle virtually does not exist. So we are going to match the right ventricle with the systemic circulation. If we have to pick a single circulation to pump into either the pulmonary or the systemic, we are going to choose the systemic because it's the one with the higher pressure. And so, if we're going to take our only functioning ventricle and match it with the systemic circulation, we need some way for blood to get into the pulmonary circulation. Fortunately, the pulmonary circulation has much lower pressures, and therefore we can completely bypass the heart and make the vena cava drain directly into the pulmonary arteries. This is what we also see in other congenital heart diseases, such as, for example, tricuspid atresia, as well as pulmonary atresia with a severely hypoplastic right ventricle. So that's part of why I like to think of hypoplastic left heart syndrome as the inverse of tricuspid atresia. Even the surgical correction is somewhat similar. So we only have one ventricle and we want this ventricle to be pumping into the systemic circulation. Accordingly, the first procedure, the first stage of this staged reconstruction, the Norwood Procedure, will then form a neo-aorta from the root of the pulmonary trunk and the original hypoplastic ascending aorta. By sewing them together with a patch, we now get a neo-vessel, a neo-aorta that's draining the right ventricle into the arch of the aorta. Therefore, now the only ventricle we have, the right ventricle, is pumping into the aorta and the systemic circulation. We will also perform an atrioseptectomy because we want the right and left atria to become pretty interchangeable. We know they are going to work as a single chamber, since you are pretty much getting rid of the right heart for pulmonary circulation purposes, and so we don't want anything to impede the normal blood flow. So we are going to remove the septum between both atria. And at last, now we have the right ventricle, our only ventricle, draining into the systemic circulation, into the aorta. However, we still don't have anything draining into the pulmonary arteries. So we still have a mixed saturation system in which blood being pumped by our only ventricle is going to go into both the systemic and pulmonary circulations, for now. But we are thirdly going to substitute the patent ductus arteriosus with a surgical shunt, either a Sano shunt from the right ventricle to the pulmonary circulation, or a Blalock-Taussig shunt from one of the arteries that emerge from the aortic arch to the pulmonary circulation. The reason we want to create our own shunt rather than just leaving the ductus arteriosus patent is, first, because it may close, and second, because we don't want all the pressure from the systemic circulation to just be spilling over to the pulmonary circulation. We want the pressure in the pulmonary circulation to be relatively low, particularly thinking ahead about the next procedure, and so we want to limit the amount of blood that goes from the aorta, from the neo-aorta, to the pulmonary circulation now. This, the Norwood, the fourth stage, is the most complex and also the most dangerous. Then, on a second stage, we will have the Glenn procedure, which means basically we'll be diverting the superior vena cava directly into the right pulmonary artery. And then the third stage, the Fontan procedure, which means we will be diverting the inferior vena cava into the right pulmonary artery. Basically, the Glenn and Fontan procedures, which we've seen before in other conditions, is essentially bypassing the right heart so as to not mix up deoxygenated blood with oxygenated blood. With the Norwood procedure, with the first stage, we had already matched our single ventricle with the systemic circulation, which is what we want. Perfect. But we also still had mixing between oxygenated and deoxygenated blood in the right atrium and the right ventricle. Both systemic and arterial blood were sharing those chambers, and so we still have mixed saturation blood being pumped into both the neo aorta and the pulmonary arteries. By diverting the vena cava completely directly into the pulmonary circulation, bypassing the heart, we have all the systemic deoxygenated blood draining directly into the pulmonary arteries and from then into the lungs, and therefore not mixing up with the oxygenated blood coming into the heart through the pulmonary veins. This blood will arrive at the left atrium, then flow seamlessly into the right atrium, from there be pumped into the right ventricle, and the right ventricle will then pump it into the neo aorta. That is, we've just turned our heart into a pure systemic circulation oxygenated blood heart. Deoxygenated blood is no longer going through the heart, it's just bypassing it entirely. Of course, after stage 2, the shunt placed on stage 1 is ligated. There are also some recent variations of this procedure, such as the hybrid stage 1 procedure, for example, in which, rather than placing a new shunt, a Sano or Blalock-Taussig shunt, we elect to maintain flow to the pulmonary arteries by simply placing a stent into the patent ductus arteriosus to make sure it will definitely remain open, and instead restrict pressure to the lung vasculature by actually placing bands in the pulmonary arteries, thus ensuring that not all the flow from the ductus arteriosus reaches them. These are all considered palliative surgeries and not an anatomical repair, since we are dramatically changing the structure of the heart, and rather than repairing it to what it should be, we are actually just making a mostly functional machine out of what we have. Still, they've been revolutionary in the sense they've massively improved survival, which used to be 0% before. Thank you for watching this video and for choosing to spend your time with me. I hope this has proven useful. Please bear in mind that this video is not meant as medical advice, only as a review. If you believe you or someone you know may have HLHS, please seek your healthcare provider. If you believe one of our patients may have hypoplastic left heart syndrome, please check the latest protocols. Thank you once more for choosing to spend your time with me. And if you are interested in congenital heart malformations, please check my playlist on it, as well as my videos on other medical themes. And I hope to see you on my next video.